and what sort of diagnostic process there is, very broadly defined, when a clinician or clinical psychologist is looking to assess somebody for schizophrenia. So let's begin. First thing you need to remember is that schizophrenia is classified as a psychotic disorder. Psychotic disorders are defined as disorders where there is a break from reality. And in fact, if you start to look at the word schizophrenia itself, you will see schizo actually stands for split, and phrenia represents mind. So schizophrenia is really it's a disorder which represents a complete disconnect or break from reality, which is why it is called a psychotic disorder, classified within the range of psychotic disorders in clinical psychology. And as I also mentioned about this split mind, you can see this here. And this little diagram is simply supposed to show you that when a person has schizophrenia, you will see activity in regions of the brain where a typical person who does not have schizophrenia would not have that kind of level of activity. So again, something to keep in mind. Also remember that schizophrenia is classified as a heterogeneous disorder, and what this means is that it has multiple causes, and I'll take you back to the nature versus nurture debate that you really learned in AS, and you should know it underpins all of psychology. But when you talk about schizophrenia, it's also a very good example of how it's not always possible to separate between nature and nurture, nor should we really, because nature and nurture interact with each other to produce behaviors and also, in this case, to produce psychological disorders. To be more specific, schizophrenia is classified as a heterogeneous disorder because you see that there are genetic components to it, there are environmental components to it, and there are also other physiological components to it, as I was just talking about when I was telling you about the activity in the brain regions of a person who has schizophrenia. Last thing you should know is that it is a chronic disease. It is a chronic disorder, rather it's a chronic illness. Chronic means that it is constant. It is not something that will only occur in an episode. It is something that is ongoing. So for example, if you get the flu every winter, that's not a chronic illness. But if, God forbid, you have some sort of deficiency, let's say you have anemia. Anemia can also be chronic. It's a chronic iron deficiency. So you have to be very careful to prevent it from adversely affecting your health. Now, these are the three basic characteristics of schizophrenia, that it is first of all a psychotic disorder. People who have schizophrenia are not able to differentiate between reality and between what is in their imagination. People who have schizophrenia may have it because of multiple reasons. There is a genetic component to it, but it can also be triggered by severe environmental stress factors, and it can also be something that is made worse by physiological processes, by a lack of control, for example, in the levels of dopamine within a person's brain. And so again, multiple causes, very complex, heterogeneous illness, and it is one that is chronic. It is not something that is episodic. It is an ongoing, lifelong condition that then has to be managed. So now we're going to go on and look at two key stages within the within the development of schizophrenia. Now, when you're trying to ascertain whether a person has schizophrenia or not, it's called a diagnostic process. Within the diagnostic process, and we do dive into everything in more detail as you move through these lessons, but broadly speaking, what you need to know is that typically when a clinician encounters somebody who's brought in who may have schizophrenia, if the symptoms are mild, but they do fall into the symptoms that are associated with schizophrenia, that person can be seen as being in the prodromal stage. The prodromal stage is also a stage that is quite difficult to diagnose schizophrenia in, because the symptoms are quite mild. The core symptoms are mild, and it is hard, especially also in children, and you will learn that when we talk about the example study. But this stage is the prodromal stage, and it is difficult to accurately diagnose schizophrenia at this stage. But sadly, the other reality is that about 70% of the people who are in the prodromal stage will go on to develop what we call the active stage of schizophrenia, or full psychosis within schizophrenia. And the active stage is where all of the symptoms that I'm going to talk about in just a minute, where all of the symptoms are no longer mild, the symptoms are severe, and when a person has reached the active stage, it is again a more complex process of treatment, and you will also learn a little bit more about that when we look at the example study, and then later as we move through the causes. So just basically remember that diagnosis at the prodromal stage is quite difficult to make, because the symptoms are mild and it's hard to tell if they are actually schizophrenia symptoms or are something else. And when a person reaches the active stage, which 70% of prodromal people may, then it is a point at which the symptoms are severe, they are persistent. So let's look at how the diagnosticians or the clinical psychologists actually ascertain the presence of schizophrenia. What do they use? So you already know that there are two sort of very commonly used diagnostic manuals. You have heard about the DSM-5 in our prior lessons, and you have also been told about the ICD-11, which is the International Classification of Diseases. The ICD-11 is essentially the 11th version of this ICD, or of this manual, and it's published by the World Health Organization. It covers all sorts of diseases and disorders, including mental illness or psychological disorders. For your purposes within the Cambridge syllabus, you are going to be using the ICD throughout for all of your different psychological disorders that you're going to study. But what you should know is that within the ICD, the way diagnosis is made is that for schizophrenia, and let me just specify that. For schizophrenia, the clinician has to look at 6 dimensions of symptoms, or rather symptoms are ranged across these 6 dimensions, and within each dimension there is a 4-point scale. That 4-point scale goes from not present all the way to severe. Right? So you've got not present, mildly present, not severe, and severe. And then the other thing the clinician has to do is that, let's say they look at the symptoms and they say, okay, well, hallucinations, which we'll talk about later, are present, and they rate that at a severe for hallucinations. But the clinician also needs to make sure that the symptom of hallucination is not, for example, because of drug abuse. So within the diagnostic criteria, there are certain things that you need to ascertain. The first thing is the clinician will rank, he will actually rate across these 6 dimensions. For each of the dimensions, which symptom is how severe or not present, and Also, during this, must ensure that if a symptom is present, it is actually not for any other reason, such as drug abuse or other medication, for example. And there are also certain symptoms that will not be indicative of schizophrenia, and that means simply that they may indicate the presence of a different disorder. So clinicians have to be extremely careful when they are using this diagnostic criteria within the ICD-11 to ascertain whether somebody has schizophrenia or not. So now let's look at these positive, negative, and other symptoms very, very quickly, and you will be covering them in later lessons. So the first positive symptom, and these are core positive symptoms, meaning that they are extremely central to the diagnosis of schizophrenia. The first one is hallucinations. So something felt or seen or heard, but it doesn't actually exist. The second one you need to know is the feeling or experience of being controlled by an outside influence. So experience, let's just call it experience of passivity. Passivity is a state where you feel like you can't do anything, you have no control over anything. Then you've got delusions. Delusions are essentially false and fixed beliefs that actually completely contradict reality. So these are the three core positive symptoms. There are other positive symptoms as well. Positive simply means the presence of psychological dysfunction. Negative, on the other hand, means the absence of psychological functioning, or rather the absence of what are normal psychological functions. So negative symptoms will include, for instance, they include something called asociality, which is complete social withdrawal, complete isolation. And you know that human beings are by nature social animals, so again represents the absence of normal psychological functioning. Another example of negative symptoms is called alogia, where the person essentially stops talking. Again, communication or language, you'll remember this from cognition, is a really fundamental part of being a human, and so this does represent the absence of normal psychological functioning. Yet another example is something called flat affect. Flat affect is the inability to really have any sort of emotional expression the way that a typical person would. If you have schizophrenia, you're not able to. And then some other symptoms which may overlap with other disorders, for example, are sadness and aggression. So again, you're seeing that there's a very complex set of symptoms that represent schizophrenia, and within these symptoms, as you will learn in our later lessons, there's a lot more to really look at for the clinician. So this very broad overview of these symptoms. Remember, positive means the presence of dysfunction, negative means the absence of normal, typical psychological functioning, and there are other symptoms. They are related to mood, they are related to cognition, and sometimes also behavior. Now, lastly, we're going to talk about the onset and prevalence of this psychological disorder. So onset essentially means when is it most likely for a disorder to begin, okay? And prevalence means at any given point in time, how many people have the existing condition. Meaning that it is not a new case that has just been diagnosed, it already exists within that population. And here what you're looking at is prevalence within females and males. So when you talk about onset, you will actually find that onset in males and females is quite different, and we'll look at that in a second in terms of age, how old men and women typically are when they develop schizophrenia. And prevalence, however, for men and for women, for males and females, prevalence is very similar, meaning that a similar percentage of men and a similar percentage of women in an existing population will have schizophrenia at a given point in time. So when we're talking about onset, as you can see here, this dotted line is for female schizophrenia patients. This is taken from a recent research paper, and as you can see that for female schizophrenia patients, onset is around the late 20s. However, for male schizophrenia patients, it is around the early 20s. And that is just a small thing that you should keep in mind, because for different disorders, you will see this again. Onset and prevalence can be different based on gender. In the case of schizophrenia, prevalence is similar, but the age of onset is different in men and women. Lastly, remember that it is rare to see very early onset schizophrenia cases, meaning children who have schizophrenia are rare, or adolescents. Now let's sum it all up. So schizophrenia is a chronic illness. It is continuing. It represents a complete break from reality. It is a psychotic disorder. It is heterogeneous. It has multiple causes. It has two different stages, the prodromal stage and the active stage. Prodromal is when the symptoms are quite mild. Active is when full psychosis has set in. There are 6 dimensions of symptoms within the ICD-11, and for each of these dimensions, the clinical psychologist rates the patient's demonstration of symptoms on a scale of 1 to 4, not present to severe. There are gender differences in the onset of schizophrenia, the age of onset, but there aren't any as such in the rate of prevalence. And cultural differences should be accounted for because, for example, hallucinations as diagnosed as pathology, which is where you see that there's a presence of a disease. In the case of schizophrenia, if you're trying to ascertain whether someone has schizophrenia because they're hallucinating, you must also keep in mind that in some cultures, for example, shamans in Latin America will consume certain hallucinogenics in order to hallucinate, and that does not mean that they have a pathology. That does not represent schizophrenia. So just some basics for you to keep in mind as we now dig deeper into the symptom sets. Hi, so in this lesson, we're wrapping up our little topic of diagnosing schizophrenia with this last lesson on diagnostic considerations. In this lesson, I'm going to very quickly just take you through how you can evaluate diagnostic process and tools. We will begin by looking at the DSM and the ICD together. You'll remember the DSM from your very first lesson. The DSM is a publication of the American Psychological Association, which we also call the APA. So it's very commonly used in the US and it is in its 5th edition right now. It was first published in the 1950s. The ICD-11 is published by the World Health Organization, and unlike the DSM, the ICD actually is, it covers a lot of different types of disease areas, not just mental illness or disorders. But the ICD is importantly an international manual, which means that it takes great care to be more culturally inclusive. Now, with reference to schizophrenia, you will remember that the ICD has 6 dimensions in which it then rates the severity of each of those dimensions on a scale from 1 to 4, right? On the other hand, the DSM has 6 criteria, of which category A is the one where you would see those core positive symptoms that we've been talking about, as well as a couple of other negative symptoms. But the other criteria on the DSM include, for example, social and, I'll just write it here, occupational functioning. So obviously the DSM criteria are a little different from those of the ICD-11. The ICD-11 requires the clinical psychologist to do what is called a clinical interview, and that clinical interview is essentially where the psychologist is able to collect more subjective information. And the ICD requires the clinical psychologist to combine the results of this clinical interview with the ratings on 6 dimensions in order to reach a diagnosis. On the other hand, in the DSM-5, sometimes it is okay to simply have those criteria judgments, but you should know that clinical psychologists, as a matter of practice, do conduct a clinical interview for any kind of new client that they're taking on, any new person they're seeing. So within the ICD, now this is an important differentiating factor, and I'd like you to keep in mind as we go through it. Within the ICD, as you can see here, the clinical psychologist is able to make a diagnosis if these 6 dimensions, particularly core symptoms, the core positive symptoms we've been talking about, if one or more of them has been present for 1 month, then using the ICD, the clinical psychologist is absolutely able to make a diagnosis for schizophrenia. On the other hand, with the DSM says that in totality, the person should have been suffering some psychological disturbance for 6 months at the very least. Continuity of disturbance over 6 months. Within this 6 months, the DSM also requires that the person should have been showing 2 or more of those core symptoms, which would be part of category A, for at least 1 month. And so what this means is that a DSM diagnosis automatically takes longer. On the other hand, the ICD diagnosis is quicker. So remember that, and now we're going to look at the issues and debates, and within that you will understand why I took you through this diagnosis process. So the first issue and debate is around the use of children in research, and this is specific to the example study you just covered by Dr. Aneja. This boy who was 14 years old when he came to Dr. Aneja had symptoms growing from prodromal at the age of 10 all the way to active schizophrenia or full-blown psychosis at the age of 14 years old. But what you have to think about in terms of the issue that's applicable here is informed consent. The boy, the child, basically is in a vulnerable state, right? All children are vulnerable, but this is a child who is currently suffering from psychosis. So there's psychosis in this child, which makes them more vulnerable. Of course, Dr. Aneja did take consent from the mother of the boy to do the research or to develop the case study and then to have it published, but this does raise an issue. The issue here really that I would like you to think about is that what is the cost versus benefit of his research? And you can see that the benefit actually is greater because VEOS, very early onset schizophrenia, is very, very rare. So you can really think that the research he's done has added a lot of knowledge and value to that field where people don't know much about very early onset schizophrenia, and the boy was not harmed as far as we know, as far as the case is written. And so we can assume there's less harm to the boy because he did get treatment. And so that was how you would resolve this issue of the use of children in research when you think about the Aneja case study. Next, we're looking at applications to everyday life, which is another issue you'll remember from your AS level studies. When we are talking about using the DSM or the ICD-11, as we've just talked about, right? I told you that the DSM diagnosis is a little slower than that of the ICD. This has implications for when treatment can begin. In schizophrenia particularly, we know that early treatment has implications. It is correlated actually to better outcomes. And outcomes, when we're talking about psychological disorders, essentially means the likelihood of the person enjoying a better quality of life and being able to manage the condition in such a way that they are able to now again have some semblance of normal functioning in their everyday lives. So the time of treatment, when you think about how the ICD is applied to everyday life in terms of how it helps to diagnose the condition of schizophrenia, you should think about the time that it saves time. The ICD is more efficient. But because it is quick, is the diagnosis as reliable? And the reason this is an issue is because the symptoms of schizophrenia can change over time. So, for example, in the 4th edition of the DSM, there were these types of schizophrenia. So you had, for example, you had catatonic schizophrenia. I won't get into what that is, but just, this was a subtype of schizophrenia. But what they've done is that they have, in the 5th edition, they have basically removed the types of schizophrenia because they realized that some of the symptoms they were using to categorize those subtypes no longer apply from over time, because the symptoms of schizophrenia can change over time. What this means is that a person who may not be experiencing hallucinations at a certain point in time but is experiencing disorganized behavior will later go on to develop those hallucinations. So they realize this, and hence in both the DSM and the ICD, the symptoms change over time is an acknowledgement. The DSM deals with this by extending the duration to 6 months, but for the ICD, this means that the diagnosis needs to be checked over time because symptoms can change. The level of severity may need to be assessed or reassessed rather. And then there is also this case of overlap of symptoms, which I have mentioned in earlier lessons. But basically, some of the symptoms can overlap with, for instance, autism, or they may overlap with depression or depressive disorder, as it is called in proper technical terms. And so it's very important for clinicians when they are using a book, a document, a tool like the ICD-11 or the DSM-5 to think about symptom overlap. They have to really reconsider very carefully. The symptoms change over time, so they have to look at the temporal development of the condition of schizophrenia as well. So when you think about how this diagnostic tools and criteria are applied in the real world, think about the timing of the treatment, the reliability of the diagnosis, whether it comes from ICD or DSM, and think about the possibilities of the overlap of symptoms. The last issues and debates that we're going to look at, the last two. The first is cultural differences. We have spoken about this at length in previous lessons as well, where for the diagnosis of any psychological disorder, where disorder really is supposed to represent that the person is thinking, feeling, and behaving in ways that are socially deviant or that are not considered to be the norm, you must then also consider the cultural background of the person. For example, in Maori culture, there are these people called matakite, and they are prophets or visionaries in the culture, and they literally hear voices and then narrate what they've heard. So this is not pathological. Remember, pathology indicates the presence of disease. So this example of the Maoris who can hear voices does not mean that they are having auditory hallucinations. This is not a pathology. And this is why it's important to be aware of cultural differences when the clinician, the clinical psychologist is conducting the diagnosis, because the symptoms are subjective. The person is self-reporting most of the symptoms in terms of just saying, you know, I can see this, or the aliens are taking my thoughts away. There's so much subjectivity in determining what the symptoms are. It's important to keep cultural differences in mind so that something that is culturally fit for the person, depending on where they come from, is not pathologized for no reason. And the last thing we're going to look at is the idiographic versus nomothetic debate. And the good thing here about the ICD is, you know, the clinical interview plus the dimension rating. So these dimension ratings come from sort of, you know, this universally applicable, they are universally applicable standards by which people are assessed for the presence of schizophrenia, which, if you guessed it, full marks, makes this nomothetic. On the other hand, the clinical interview, and the purpose of the clinical interview is to provide a clinical psychologist with insight into the individual's experiences. It's completely subjective, and full marks if you know by now that this means it is idiographic. It looks at the individual experience. And so you can see that when you think about the ICD as a diagnostic tool, you must think about its application to the everyday world in terms of treatment timing and reliability of diagnosis and the overlap of symptoms, but also you must think about how the clinical psychologist, or to what extent are they accounting for cultural differences, and the fact that the ICD is incorporating an idiographic approach alongside a nomothetic approach does make it a very powerful diagnostic tool. So this brings us to the end of our lessons all about the diagnosis of schizophrenia. As we move on, you will be looking at the key study, which is all about the persecutory beliefs, the delusions that people have that they are being persecuted by an external body or person. So that's going to be our next set of lessons. Hello, and welcome to this lesson, which is about an example study. And the purpose of this example study, which is a case study that was conducted by Aneja et al., was published in 2018. This example study will show you the diagnostic process by telling you about a case of very early onset schizophrenia. So we'll first start by looking at very early onset schizophrenia and then move on to this specific case. So let's get into it. Very early onset schizophrenia is basically schizophrenia that is found in children or in adolescence, where adolescent is defined as between 13 to 17. Very early onset. Now, onset here means emergence or beginning of the disorder. And so in very early onset schizophrenia, this particular case is about schizophrenia in a male child. And you'll remember from our previous lesson that onset in males is typically around the early 20s, when you see men who have schizophrenia develop full-blown psychosis, meaning that they are in the active stage by then. In childhood cases, diagnosis is quite complicated because a lot of the symptoms are initially quite mild and they can fall into the prodromal stage. And you'll remember this again from our previous lessons about the severity of symptoms becoming worse and worse as the person progresses into the active stage. So as far as males are concerned, usually you see schizophrenia onset in the early 20s, but in this case will show you that you can actually find cases of VEOS or very early onset schizophrenia in children. And this particular case is about a child who's 14 years old, but as you will see, from the age of 10, some psychological disturbance, some symptoms start to make themselves visible and they become worse over time. When you are talking about very, very early onset schizophrenia, you must remember that for childhood cases or for cases of schizophrenia to be classified as childhood cases, they must be less than 13 years old for the first symptoms of psychosis to emerge. Remember, psychosis meaning symptoms that indicate a disconnect from reality. So do keep that in mind. And it's different. Very early onset schizophrenia is different from adult schizophrenia, such like that which would emerge in the early 20s. It's different because the symptoms are expressed differently. It's also because it's quite rare and because the sort of treatment and the eventual outcomes are also different for VEOS schizophrenia. So keep these points in mind as we now move into our case history. So this particular case that was published by Dr. Jitendra Aneja in 2018 is about a 14-year-old boy. And there are a few things that you should keep in mind about this boy. He was born into a two-parent household and it was a normal pregnancy. All of his developmental milestones were met, meaning that in terms of cognition and motor skills, meaning movement, and behavior, up until the age of 10, he was developing as he should have. Everything was age appropriate. However, what happens is, what you should also know is that this whole time he had a very aggressive father. There was apparently some history of abuse or violence that the child himself was exposed to. So I think the child was beaten by the father on occasion as well. And all of this is happening before the child turns 10. So what happens when the child turns 10? When the boy turns 10 years old, his parents get divorced because of this incidence of domestic violence, which I think you can trace also back to the father being very aggressive. When the parents get divorced, the boy moved in with his mother, with his grandparents. But by the age of 11, there were some causes for concern, which involved him having many fights at school. There were many complaints. His academic performance really declined. There was a decline in his schoolwork. He started to demonstrate sadness. He became quite irritable, and he was then taken to a doctor, a psychiatrist, I believe, who prescribed sodium valproate, which is actually a medication that is used for bipolar disorder. And you'll study bipolar disorder when you talk about, when you study mood disorders later on in this course. So he's given this medication of sodium valproate, and his sort of anger issues subside for a little while, and the behavior and the sadness kind of becomes a little better. So you see that this prescription temporarily alleviates his symptoms. Alleviates meaning makes them milder, reduces them. So there's temporary relief from the symptoms. However, again it starts to get worse, and by the age of 12, you see that the boy is now hearing voices. He stops to take care of himself in terms of his hygiene, in terms of his clothing. He starts to have sleep disturbances, he stays up very late, and his family sees him often talking, muttering to himself. He is now on other medications and he has been hospitalized because of his excessive violence, his outbursts of violence and aggression. By the age of 14, the boy is finally brought to Dr. Jitendra Aneja's clinic. At this point in time, he is termed what is called non-cooperative. Non-cooperative is when a person who has a psychological disorder is brought to a physician and they are not willing to talk, are not willing to cooperate with, let's say, if a IQ test has to be administered, which Dr. Aneja did try and do to establish more of a baseline. But the boy refused to cooperate. He was extremely aggressive and his hallucinations had become very, very severe by this time. So this is your entire case history, and these are very important details. You remember from your AS syllabus, case studies are predominantly, they are idiographic, meaning they focus on the individual experience and they really do tend to capture things that are rare. And you will remember also that VEOS is a rare condition. And so this is the boy's case history over from the age of 10 to the age of 14, before which he did have a very difficult home environment with domestic violence, with violence from his father against him. And by the age of 10, he starts to develop these symptoms. And now let's look at what happened, what these symptoms actually were. So in this boy's case, the positive symptoms, which are the presence of dysfunction, of psychological disturbances. The positive symptoms in the case of the boy at the time at which he was brought to the clinic at the age of 14, he is hearing voices, and this you will recognize as an auditory delusion, auditory hallucination. He is also at this point very suspicious of his mother, and you will recognize this suspicion as a delusion that is persecutory. So he has a persecutory delusion, and you're already seeing now two of the core symptoms have emerged. And then he also was muttering to himself, he was laughing and shouting at unseen others. This behavior really exhibits a delusion, which we call a thought echo, possibly a thought echo. Thought echo is when a person who has schizophrenia can hear their own voice out loud and they start talking to themselves by hearing their voice out loud. So there's an element also here of hallucination, especially when you consider that he's shouting at unseen others. So there's that, let me just fix this. Yes, there's that hallucination element as well. And these are his positive symptoms. By the time he's at Dr. Aneja's clinic, these symptoms are quite severe. But there are a few other symptoms as well. Negative symptoms, which you will remember, are when there is the absence of normal psychological function. And what had happened to the boy was that he preferred to be alone. He refused to eat dinner or have meals, for instance, with his family. And you will remember this is what we called asociality or social withdrawal. And then you also see that he stops. Then you also hear from, and this information is also coming from his family, by the way, who tells Dr. Aneja that he has also stopped talking, and here you can see clearly there's a presence of alogia. And lastly, there is a lack of self-care. Now, this lack of self-care is actually not necessarily classified as a negative symptom, but it is one of the other symptoms that we had talked about in our very first lesson about schizophrenia. It's one of those other symptoms which is related to behavior, cognition, and mood. You remember that. So again, you see that this lack of self-care does represent a negative symptom in that it is what you call not adaptive behavior. It's not normally functioning behavior. So in that sense, you could consider it as a negative symptom. So these are his core. You can see in this boy, you have three of the core positive symptoms, really, because if you consider the fact that he has this suspicion of his mother and he's hearing voices, perhaps it may not be entirely wrong to assume there may have also been an experience of passivity or lack of control which may lead to the aggression. However, in the case history that we have received, we know that he has auditory hallucinations, persecutory delusions, and potentially also some other sort of delusion and hallucination. Visual hallucination. Maybe he is also seeing other people, and you see these negative symptoms present where he is asocial and he doesn't talk much and he has disorganized behavior or not adaptive behavior. So what did Dr. Aneja do in this case? He had to seek a great amount of clarity in his diagnosis because at the time that the boy was brought to the clinic, he already had seen two different doctors. He had seen two different psychiatrists. He had received by this time a schizophrenia diagnosis, but it wasn't a firm diagnosis. He had also been on multiple medications by the time he came to the clinic. From the sodium valproate, he was then given other combinations of 3 or 4 other drugs as well. And he continued to have these routine hospitalizations because he would have aggressive outbursts. And so really for Dr. Aneja, diagnostic clarification was a long process because he really had to, what he did was that he reduced the medication, which seemed to make things better for a few weeks. But after the boy went home, he once again had to be readmitted because the symptoms came back and they were worse than they were before. And so then he, let's call this step 1, even though step 1 was actually a different kind of assessment, but for our purposes right now, Dr. Aneja reduces the medication, he sees the symptoms again reappear and they are worse, and so he puts the boy on new medication, but then he also prescribes this electroconvulsive therapy, which is also called ECT. You may recognize it in popular culture. It's called shock therapy. So he prescribes shock therapy, and you learn more about this in detail later. So he prescribes shock therapy, and at the same time, he takes the additional steps of having the boy more active in what is called occupational therapy, which is, really involving motor skills and movement. And he gets the boy enrolled in psychotherapy, which is talk therapy. And he also takes this very important step of educating his family better about the condition that the boy has and how to manage it, and how to respond to him when he's very aggressive or when he's extremely delusional or having very strong hallucinations. So this is sort of the process he follows for this very complicated case of very early onset schizophrenia. Putting it all together, why do you need to know this example study? What can you use it for? First of all, it tells you about the diagnostic process and how important a detailed case history for a patient or client can be for a treating clinical psychologist, because the boy's case history is what told Dr. Aneja about the boy's history of abuse, about the troubled family life, about the problems in school, about the aggression that the boy was exhibiting, about the development over time of the core symptoms, If you recall, from age 12 to 14, the hallucinations became quite severe. It also tells you how complex very early onset schizophrenia is compared to adult onset schizophrenia, which is more common. Very early onset schizophrenia is a rare condition. This case shows you how a person can progress from the prodromal stage to the active stage. If you recall, the boy's difficulties really did begin with milder symptoms where, he initially just had trouble at school, he was getting into fights, and then it goes into full-blown psychosis, which is indicated by the hallucinations that he was having by the time he was 14 years old. And lastly, this case demonstrates an extremely important point, and you should keep this in mind as we move through the treatments for schizophrenia as well, that for schizophrenic, for cases of schizophrenia, it's important to use combinations of different treatments. Dr. Aneja used different medications, which are also referred to as biochemical treatments. He also used psychotherapy. He also uses electroconvulsive therapy or ECT, and he uses occupational therapy. So he uses 4 different ways in which taken together, they form the treatment for this young boy. So this is why you should keep this example study, this case study in mind as you move through the rest of the course material. Hi, this is one of the key studies that is part of your schizophrenia chapter, and the purpose of a key study and the reason it's different from an example study is that when you're doing a key study, you're looking at a very specific symptom. So here we're looking at persecutory ideation, and I'll tell you why that's related to schizophrenia. It is not in and of itself a symptom, but it's related to a specific symptom of schizophrenia, which we'll discuss in this lesson. But the reason you're going to cover this key study is because this is actually one of the main studies that you're going to be assessed on specifically in paper 4 and somewhat in paper 3 with reference to schizophrenia itself, but also with reference to research methods in psychology. So you have to pay attention to the content of the study itself as well as the design of the study. It's a little different in terms of how it's assessed at the A level because it is a little more complex and it's a little less cut and dry. So you're going to start seeing overlaps between different methodological approaches within this curriculum, within the A2 curriculum. So now let's talk about this key study, what the key terms are. Now, first off, you've got this called persecutory delusions. Now, you'll remember from our earlier lessons, persecutory delusions are classified as a positive symptom of schizophrenia. And why are they a positive symptom? Positive meaning that they indicate the presence of some sort of psychological malfunctioning or dysfunction. And so persecutory delusions are fixed but false beliefs. Fixed but false. And why are they false? They're false because they contradict reality. So persecutory delusions are fixed and false beliefs about being victimized. Persecutory ideation, on the other hand, are not beliefs, they are simply thoughts. They are ideas that you are being victimized or maltreated by others, but they do not necessarily represent reality. They're just thoughts that you have. They are, in other words, not pathological. Remember that pathology refers to something that indicates the presence of disease. So persecutory ideation is not pathological. Then delusions of reference, again, you're looking at yet another positive symptom. This is just another type of fixed false belief, which is basically one of the core positive symptoms of schizophrenia. Delusions of reference refer to the fixed belief that everything happening around you has some sort of special significance for the self, which does not represent reality. So again, it contradicts reality. That's how it's false. But it is a fixed belief, it is a delusion. On the other hand, ideas of reference, similar to our persecutory ideation, is again talking specifically about thoughts that create connections between the self and external events or people, even when there is no actual connection or reference. So again, these ideas of reference are not pathological. Now, this particular study does cover extensively both these persecutory ideation as well as ideas of reference, which are related to, respectively, persecutory delusions and delusions of reference, both of which are positive symptoms related to core positive symptoms which indicate the presence of schizophrenia, if you'll recall from the ICD-11, if they are present for a month consistently, amongst other diagnostic criteria. Now, the other key terms here for this particular study is VR, which I know you're familiar with, but essentially just let's assume that you don't know. The VR is this experience of being in a three-dimensional space. So, you put on your VR goggles and you find yourself in this world which feels like the physical world, although it's not, but you'll find that you react in many ways the way that you would if you were physically present in that VR world. Virtual reality experiences often include characters which are called avatars, and you use a headset and usually a joystick as well. Now, do remember that this study was done in 2003, which is nearly 21 years ago if you're watching this in 2024. And so, virtual reality has evolved a great deal since then, but at the time the study was done, VR was quite new. It was an emerging technology. Now, this study is testing for a correlation. Quick refresher from your AS level syllabus. A correlation is simply where a relationship between two variables X and Y is being explored. Correlational studies tend to look for the likelihood that changing X will also mean that there's some sort of change in Y. And so it's not causal, it is correlational. This study is a correlational study. It's not an experiment looking to determine cause and effect, but it is an experimental study in some ways, and we'll talk about that. This study uses questionnaires. You know these questionnaires from AS, but you also know in A2 that now in A2 you're specifically also talking about questionnaires that contain 4 or 5 point scales. There you're supposed to indicate the agreement to something or the extent to which you feel something is or is not present. So keep these methodological terms in mind. And as far as the content of the study is concerned, remember VR and persecutory delusions related to related to persecutory ideation, and remember delusions of reference related to ideas of reference. These will be important as we move further. Now, what is this study really all about? This is a study that resides in the cognitive approach, but it's interesting, as you will learn, there is a component of emotional processes also being explored in this study, where the researchers basically wanted to see how cognition and emotion interact and how that interaction produces certain effects when a person is exposed to virtual reality. And that effect, the specific effect they were exploring, was persecutory ideation. You'll remember persecutory ideation refers to this sort of thought that the feeling, the sense that you are being victimized in some way by others. And again, it's a thought. They were not looking at delusions of persecution. They were not looking at persecutory delusions. Remember that? This was an exploratory study because, as I just mentioned, VR was quite new, and the researchers in this case wanted to see how VR could be applied to further understand the presence of different pathological symptoms, one of which was, and the one they were specifically exploring, was persecutory delusions. But this was a first step to that. Now, this was done in a laboratory, so you're thinking about it as a laboratory experiment, but remember, it was just an experimental design. An experimental design in the sense of exposure to the VR environment took place in a laboratory, and there were certain questionnaires that that participants were filling out. There were certain observations that were made while participants were being interviewed. And by the way, one of the self-reports that they used was interviews, but they also used 5 different questionnaires, and we'll talk about them in later lessons. These 5 questionnaires ranged from trying to assess cognitive states and emotional states related to anxiety, related to the presence of psychosis or dysfunctions in mood, and as I just mentioned, was a correlational study. Now, because it was focused on collecting quantitative data only, this means that the 5 questionnaires were obviously quantitative in nature, but even the interviews were converted to quantitative data by the researchers, because they had a clinical psychologist literally rate, using observational scales, rate the interviews to create quantitative data from within them. So this is a very quick overview, but also you should know the correlations they were exploring were specifically relationships between persecutory thoughts and ideas of reference. Ideas of reference, you remember, thoughts that everything is related to you. So they wanted to look at this relationship. Is there a relationship? If you have more persecutory thoughts, does that mean your ideas of reference are also, you have more ideas of reference, let's say, and this is how it's actually in your studies. Let's say virtual reality persecution, if there's more of that, does that mean there's also more VR, let's call it ref? Does that mean that you have more ideas of reference? And then if you have more ideas of reference, does that mean that you have, let's say, we are positive, meaning positive beliefs about what other people are thinking? Does that mean that there are going to be less positive beliefs about how other people are thinking? They were also looking at whether there's a correlation between persecutory thoughts and, I'm going to write it right under this, anxiety. So in other words, if you have more persecutory thoughts, meaning that you think more that other people around you are going to have it out for you, then are you also going to have a greater level of anxiety? So here, really you can see this relationship. The emotional state is anxiety. Here you can see the cognition, positive beliefs. So this is an example of that relationship between cognition and emotional processes that I was talking about just earlier. One term that I really want to focus on for you is interpersonal sensitivity. It will come up quite a bit, and it wasn't covered in our key terms, so I just want to go over that with you. Interpersonal sensitivity is basically where everything is centered around very strong feelings of inadequacy, feelings of inferiority, and these feelings are basically particularly in comparison with other people. And so when we're talking about interpersonal sensitivity, are you more likely to have persecutory thoughts and have higher interpersonal sensitivity is the fourth type of correlation that the researchers wanted to explore. Again, because they were focused on this relationship between emotional processes and the cognitive approach. Now, they used a sample of 24 adults. These adults were all university students or administrators, which means that you can assume a higher level of education, certain level of intelligence. They had no history of mental illness. Again, to emphasize that this was not a study about pathology per se, right? It was not about delusions of reference. It was about ideas of reference. It was not about persecutory delusions. It was about persecutory thoughts. So, a very quick overview just to give you a general sense of what this key study is around. And again, to emphasize that the way you're assessed on this key study is both in terms of your grasp of the methodology, what are its strengths, what are its weaknesses, how was it done, how was the study conducted, but also with reference to what the study reveals about, let's say in this case, persecutory ideation, which is related to delusions of persecution or persecutory delusions. And those are a core positive symptom of schizophrenia, but then that also means that, this study highlights certain areas for future research, such as what would happen if you took people who did have a history of mental illness, specifically maybe if they had schizophrenia, and you implemented this kind of study in virtual reality. What would that tell you about the experience of the symptom for the person who has schizophrenia? And then how could you use that information to develop more effective treatments? So for instance, that's the level of complexity that you should be able to achieve at the end of our next few lessons, which delve deeper into this key study. All right, this is our second lesson on the key study, Freeman et al. So first, let's talk about the psychology that was being investigated. The similar format from what you saw at AS. I'm using a similar format just to keep things in sync for you. But again, don't forget what I said in your earlier lesson, that this is really at the A2 level. It's a lot about the complexity of the material. So what was the psychology being investigated by Freeman and his colleagues? They were specifically examining persecutory ideation in great detail. Remember that persecutory ideation is different from persecutory delusions. When we are talking about persecutory ideation, we are talking about thoughts. Remember that thoughts are not fixed, and delusions are fixed beliefs. Fixed beliefs that do not represent reality. However, when we are talking about persecutory ideation, we are talking about thoughts, and thoughts about being what? Victimized by other people, being persecuted by others. Essentially, persecutory ideation refers to our thought that others have negative feelings towards us or negative intentions towards us. And these thoughts are typically also quite irrational, meaning that they usually have little to no evidence that others are actually out to get us. And they can be, for example, a very everyday sort of thought of being persecuted could be when you walk into a crowded classroom and you feel like, when you walk in, people become a little quieter. Now, people could be becoming quieter simply because someone new has entered the space and they just momentarily want to look and see who has come in. But for you, when you walk in, you might feel all eyes are on you, and hence you might feel like people are judging you in some way. Again, there's no actual evidence that people are judging you. It's just a thought that you have. It's not an entirely rational, logical thought. So, persecutory ideation, important point for you to remember is that it's not pathological. We all do it. But it is related to persecutory delusions or delusions of persecution, because persecutory ideation can, in people who have schizophrenia, who have maybe prodromal stage schizophrenia, this kind of very constant persecutory ideation can later develop into persecutory delusion. So that's the relationship there. But again, I'm going to repeat this, that persecutory delusions are a positive and core symptom of schizophrenia, which is why this study has been included in this module of yours, but it's different from persecutory ideation. Now, persecutory ideation, again, it's a thought, but it's not entirely rational, and it represents a mix of cognitive and emotional processes. So, for example, higher anxiety. So, let's assume higher social anxiety, right, where anxiety is an emotional process, could be related also then to higher persecutory ideation, or higher sense or thoughts or feelings that others are looking at you negatively, are looking askance at you, are judging you, and so they're both related, right? So persecutory ideation, you can think about it as having two components, cognitive and emotional processes, and this is what Freeman et al. Were also trying to figure out, because they had access to prior research which indicated that there is a relationship between cognition and emotional process here. So this is the psychology they were looking at. Next, let's look at the other component of the study, which is virtual reality itself. Now, at the time the study was done, again, I'll repeat it because I misspoke earlier, in 2001, prior use of virtual reality had shown psychologists or researchers in psychology that VR provides successful exposure therapy for people with post-traumatic stress disorder. I'm going to write it here, post-traumatic stress disorder, which is essentially something that you probably heard a lot now in popular culture, but it's when you have an extremely traumatic experience and that experience starts to impact your everyday functioning to the point where your life becomes unmanageable, everyday activities become impossible, and there are many triggers for that stress. But in VR environments, in virtual reality environments, people who were exposed to their triggers gradually desensitized then to those triggers using virtual reality, did show, basically virtual reality showed successful treatment for PTSD, also for claustrophobia, which is a fear of enclosed spaces, as well as a fear of heights and fear of flying. And also, this is not on the slide, I'm going to write it for you, plus VR exposure was also helpful for people who had an excessive fear of public speaking. So you can assume that essentially in these research studies, in these clinical trials, whatever was happening here, they found that VR environments that simulate the real stress or threat provide a safe means of exposure to the triggers for that phobia or for that anxiety, which are again emotional states which are related to cognitive processes. And they also found that the reason that these exposure therapy treatments were so successful is because the way that people react to VR was similar to how people react to real people in physical lived experiences. So essentially, the fact is that prior use of VR had taught the researchers, Freeman and his colleagues, two things. The first thing was that VR is successful as exposure therapy in situations where there are cognitive and emotional processes involved, meaning that VR can successfully engage these two processes. And second, that related to the first, is that our reactions in virtual reality are very closely mirrored to those of our reactions, or very closely mirror our reactions to the real world. And so really, even in 2001, where you can assume very basic kind of virtual reality experience compared to what you have today, by this time we already knew that VR is a very, very powerful tool to be used. And so Freeman and his colleagues, and this piece is directly from the paper that they published, they said experimentally altering the virtual environment has the potential to lead to the discovery of environmental factors associated with persecutory thoughts or persecutory ideation, which we just discussed. And so now you can tie these two pieces together, the psychology being investigated along with the context of the use of VR at that point in time. And so putting those two things together, where okay, persecutory ideation has a cognitive and an emotional process involved, and then also that VR is successful in engaging those processes, and that we respond very similarly in VR environments as we do to the real world, leads Freeman and his colleagues to think, well, we should explore how using VR can be used to explore or to understand whether there are personal characteristics that impact or that are related to the presence of persecutory ideation in people who do not have mental disorders or psychological disorders. Now, the potential use of VR that Freeman and his colleagues were looking at was to understand how people make sense of their experience when they are in that controlled VR setting, and that is relevant then to clinical disorders. And that is that relationship between, I'll write it here, between the persecutory delusion and ideation. So step one of this exploratory study was really to understand if VR has the potential to help researchers better understand how people make sense or interpret their VR experience in this very controlled VR environment, right? And they wanted to make sure that this experience itself is one that is relevant to clinical disorders, and that is why they were looking at persecutory ideation, which I explained earlier is related to, but not the same as delusions of persecution. Now, at the time that they did this study, there had been no prior use to understand persecutory ideation. So this is a pilot study, and you should remember it also as an exploratory study. It was looking at an idea, at an area that had not been explored at all before. And what they were essentially looking at in this exploratory study was the occurrence of persecutory thoughts in reaction to virtual reality characters who are not actually real. And they wanted to also look at, remember, they were talking about personal characteristics. So they wanted to look at whether there are certain traits or emotional states. And they were specifically looking at paranoia, and they were looking at anxiety, and they were looking at interpersonal sensitivity, which is your feelings of inferiority compared to others. So these were the traits and the emotional states they were looking at in relation to the presence of persecutory ideation. And they were again using VR to do this. And so this is a little more of the background of the study. So again, they were investigating persecutory ideation, and they were doing that using VR. Why were they using VR? Because VR had previously been shown to be effective not just in exposure therapy, but the very success of it in exposure therapy indicates that VR itself does evoke similar reactions as the real world does. And so the aims of this study were to figure out whether non-clinical individuals could experience persecutory ideation in a virtual reality setting. Why do you think they were using non-clinical individuals? They were looking at non-clinical individuals because this was an exploratory study. And for them to figure out whether this would work with people who have a psychological disorder, they needed to make sure that people who do not have a psychological disorder do react in certain ways to VR, to ensure that it was actually there was enough evidence to indicate that it was worth exploring how a person who has, let's say, a high pathological level of paranoia perhaps would respond to virtual reality. So again, this is why they were using non-clinical individuals, but they wanted to figure out if non-clinical individuals do have persecutory ideation in VR. And again, because persecutory ideation has that cognitive and emotional element to it, we were looking at what the cognitive factors are that predict the occurrence of persecutory ideation. So, for example, from our earlier lesson, positive belief could be an example of the persecutory. The relationship between positive belief and persecutory ideation in VR was something they were looking at, but then they were also looking at emotional processes. So for example, they were looking at state anxiety, which is the actual current existent presence of anxiety in your system, and its relationship to persecutory ideation. Again, they were looking at correlations. This is an important one. This was a correlational study. It had an experimental design, but not an experiment. And that is why there is no hypothesis for this study. Please remember that there's no clear set hypothesis for this study, because they did not say what kind of relationship they expected to find. They did not even know if they would find a relationship to begin with, and it was an exploratory study. There is no hypothesis for this correlational study, because there is no cause and effect relationship being explored in this study. And so there is no hypothesis. So just try and remember that here. There is no clear hypothesis of this study, and the aims, however, are whether using virtual reality can help us better understand how people experience persecutory ideation in virtual reality, including the personal characteristics, cognitive factors, and emotional processes. In our next lesson, we're going to look at how Freeman and his colleagues actually conducted this study 23 years ago. This is our third lesson covering the key study, Freeman et al., done in 2003. In this lesson, I'm going to break down the sample for you, including how the sample was recruited or selected, and the method that was used. And in the next lesson, we'll dig a little deeper and look at the actual procedure followed. But for now, you need to look at the method, you need to look at the materials and the participants. So first, we start with the sample. Freeman and his colleagues used what we call a volunteer sample. From your AS studies, you should remember a volunteer sample is when participants choose to be there. And in this study, participants chose to be there. Why? Because they were, let's say, participants choose to participate. And in this particular study, they chose to participate, they chose to volunteer their time in response to an advertisement that Freeman and his colleagues placed at University College London, which is in the United Kingdom. And obviously, because this was placed within a university setting, most of the people who responded were students at the university. So the total sample size was 24. Of those 24, 21 were students at the university and 3 were administrators at the university. Freeman had a very good gender breakdown. So he had 12 men and 12 women, 12 male, 12 female participants, and the mean age was 26 years. And so they were relatively on the younger side. They also were screened and they had no prior history of mental or psychological disorder. Remember that this research study, this correlational research study, was aiming to look at persecutory ideation in non-clinical individuals. Hence, The sample had no prior history of mental or psychological disorder, and it was recruited using an advertisement at University College London. One other important piece for you to remember is that participants received payment in exchange for their participation. And now let's look at how, or rather what the method was. So the design of this was that this was a correlational study. You can think of it as a little experimental, but that is literally only because of the fact that it was done in a lab and it used a controlled setting, and of course it used self-report. So what was this controlled virtual reality environment? They used something called CAVE, which in 2003 was all the rage in the virtual reality whatever industry. And this CAVE basically was like a 4-wall projection, and using this headset and a joystick, participants entered into the VR setting, the environment, which was a library setting. They chose a library because they felt it was more relevant for university students or people who worked in that academic environment. They felt like it had, more relatability to their everyday lives, and that's why they chose the library setting. Within that library setting, they had 5 avatars or characters. 3 were sitting on one desk, and across that desk there were 2 others at another desk. Through the duration of the exposure to this controlled environment, the avatars were basically just doing unambiguous, meaning can be interpreted anyway, unambiguous gestures. They were maybe shown to be talking, a couple of times they were shown to be smiling or laughing. But that's what the avatars were doing in this controlled VR environment. And now the self-reports that they use are quite a few. So stay with me because I'm also going to go into each of these in detail within this lesson. Now, they used five questionnaires and a semi-structured interview. Do recall, as I mentioned in an earlier lesson, that this study used quantitative data only. And these questionnaires, hence you can imagine, they are all closed-ended. They all use rating scales. They're all a little bit different, but essentially they use something called the Brief Symptom Inventory, the BSI. They use the Spielberger Berger State Anxiety Questionnaire. State anxiety is the current feeling of anxiety. Paranoia Scale, the VR Paranoia Questionnaire, and the Sense of Presence Questionnaire. Important point for you to recall, for you to keep in mind, is that this VR Paranoia Questionnaire was actually developed by Freeman et al. For this study. So it was a pilot questionnaire. And the semi-structured interview was actually videotaped, and then later it was rated by a clinical psychologist who was Freeman himself. So Freeman was the observer who rated those interviews again to convert them on a score of 6 for persecutory thoughts. So next, let's look at the questionnaire specifically. So the first questionnaire we'll talk about is called the Brief Symptom Inventory. This is a widely used questionnaire, and it is a clinical assessment. It assesses anxiety, mood, and psychotic symptoms. So symptoms are signs of mood disorder, psychosis, anxiety disorder. So they were looking at, so the BSI looks at anxiety, mood, and psychotic symptoms over the last 7 days, and the dimensions that it looks at to cover these areas of anxiety, mood, and psychosis are interpersonal sensitivity. Remember this, our definition from earlier lessons, this heightened feeling of inferiority that comes up when you compare yourself to others. I'm going to write it for you as well. And then depression, which is your mood, hostility and paranoid ideation, paranoid thoughts, again, related to mood, but could also be related to psychotic symptoms. And so this is a 53 item scale. And it is, again, brief symptom inventory. So it's focused on these symptom areas. The next questionnaire they used was the paranoia scale, which was developed by Fenigstein and Vanabel in 1992. This has 20 items rated on 5 points to measure paranoia in college students. So it's really specific to college students. The range of scores in this paranoia scale, Fenigstein and Vanabel scale, is between 20 to 100, which means the minimum score is 20, the maximum is 100. And it is a 5-point scale, and it specifically looks at ideas of persecution, persecutory ideation, and ideas of reference, both of which you will understand are very relevant to our study. And then the third one they used was called the Spielberger State Anxiety Questionnaire. It's again 20 items, similar to the paranoia scale. These 20 items, however, are marked on a 4-point scale to measure state anxiety, and scores are between 20 to 80. So you've got so far a symptom inventory, which is looking at anxiety, mood, and psychotic symptoms, and a paranoia scale, of course, looking at the existence or the level of paranoia specifically made for college students, which includes persecutory ideation and ideas of reference. And you're looking at a state anxiety questionnaire, which is looking to measure the level of anxiety a person has. The BSI focuses on symptoms in the last 7 days, while the paranoia scale looks at general sort of notions of paranoia levels, while the state anxiety looks at the current state of anxiety a person is experiencing. So there's a mix of cognitive and emotional assessments within these 3 questionnaires. Now the next two questionnaires we'll talk about are the virtual reality paranoia scale. This is the one I was telling you was developed by the researchers to measure situation-specific persecutory ideation. You'll recall I mentioned this is an exploratory study. So at the time the study was done, the researchers found that actually there was no other scale that existed at the time that measured situation-specific persecutory ideation, meaning that there was no scale to assess the kind of ideas of persecution or thoughts of persecution that emerged specific in a particular situation. And that's why they developed this VR paranoia scale. Now the VR paranoia scale covers 3 areas. So it covers persecution, it covers positive beliefs, and it covers ideas of reference. And as we move through the study, what I'd like you to remember is this is VR persecution, VR positive beliefs, and VR reference. They're literally written like this for much of the other lessons, so that's how I'm just going over that right now. Then you've got the sense of presence questionnaire. This is just 6 questions on a 7-point scale. The whole point of the sense of presence questionnaire is to determine the extent to which somebody feels like virtual reality is mirroring, parallel, or just like the physical reality that they're in. So it's really about how there do you feel, how present do you feel in that VR environment, with the sense of, actually being in the space instead of seeing pictures of it. So it's less than just, it's more than just seeing, or okay, you can visually, you can literally see that you're in this 3-dimensional other reality, but you really actually feel like you're in it. It's not just about what you see, it's about how you feel in that space, that sense of presence again. And it's also checking the extent to which the behaviors, the reactions, the responses, the feelings that you have in a VR space are matched by the ways in which you would feel or think or act in a physical environment. So this is the sense of presence questionnaire. And then you've got the semi-structured interview, which is the 6th self-report. Now, this is done immediately after the VR exposure. VR exposure, FYI, was for 5 minutes. And the point of this was, first of all, what are your spontaneous in the moment, what are participants' spontaneous in the moment impressions of that VR experience after 5 minutes of being in it. Remember that these were videotaped, but also it gave participants an opportunity to tell the researchers about any kind of distress that they felt when they were in that VR space, and this does have certain ethical implications. And as you'll see when we look at the procedure, you'll understand why, but just remember a tiny bit here. And so this semi-structured interview, remember semi-structured interviews have set questions, but also the researcher can ask other questions depending on the direction of the discussion. So there is some degree of standardization within a semi-structured interview. And that degree of standardization is what helps the researcher, Freeman, who's actually a clinical psychologist, with experience of persecutory ideation in that field. And so he then rated those videotaped interviews on a 6-point scale for persecutory content, and basically was looking at statements that people may have said during that interview that may indicate the presence of persecutory ideation. And so we'll go back to our first design and material slide. So you've got these 5 questionnaires and 1 semi-structured interview, and together they give you really the materials that are used along with a controlled virtual reality environment where there's a library setting, which is remember this please, the setting is chosen because it's relative or relatable actually for the university population that was part of the study, the sample that was part of the study, but also it was a very neutral setting. And neutrality is very important to this experiment, as you learn further when we dig into the procedure followed in our next lesson. For now, remember the design, the materials, and of course the volunteer sample that was chosen using an advertisement, very gender balanced, 12 male, 12 female. 26 is the mean age. Interesting because schizophrenia onset, by the way, is also around that age, but that's a different layer. I'm again referring to these ideas not to confuse you, but simply because that's the level of complexity, and that's how you need to link learning together. So anyway, in our next lesson, we're going to dig deeper into how these materials were used and what were the essential procedures followed during the study. Hi, and welcome to the 4th lesson in the Freeman et al. Key Study Lesson series. In this lesson, I'm going to take you through the procedure, which is related to the materials and the method that we talked about in our previous lesson, and you'll figure out or you learn how the sample was used in the course of this exploratory study. Before we jump into the method, a quick refresher on the design and the materials. Remember, this is an experimental study. We're using the word experimental simply because of the controlled conditions in which this study was done. However, it is an exploratory study and it's looking for a correlation. And also remember that this study makes great use of self-reports. However, all the data collected from the self-reports remains quantitative data. So keep that in mind. The controlled setting I was talking about is created through virtual reality, where participants are wearing a headpiece, they have a joystick, and it's a very neutral setting that is created. So basically the library setting that they used is a neutral environment, which was also quite familiar for the participants because they were all university students, and hence there's greater neutrality in the controlled VR environment that was created. Within this environment, there were 5 characters or avatars present. There were 3 at one desk, 2 at another, and these avatars were engaging from time to time in what we refer to as ambiguous behavior. Ambiguous behavior meaning behavior that can be interpreted in any really way, So examples, they were from time to time smiling or just laughing or talking to each other in that VR setting. That's what the 5 avatars were doing. Now, the questionnaires that were used in this study were the BSI, which is the Brief Symptom Inventory. And the Brief Symptom Inventory looks at 9 symptom dimensions. And these dimensions, by the way, include persecutory ideation. They include, sorry, not persecutory ideation, they include interpersonal sensitivity. Remember that word, it refers to feelings of inferiority or feelings of inadequacy, especially in comparison to others. That was one dimension, but also looks at dimensions related to depression, related to psychosis, related to mood, and it looks at these as they have occurred over a 7-day period at the time at which the person is taking this inventory. The Spielberger State Anxiety Questionnaire is one that literally looks at the extent of current anxiety or the current present experience of anxiety. And then you've got the paranoia scale. This one was made specifically for college students to determine the extent of paranoia present in a college student. The higher the score, the higher the proposed level of paranoia. And then you've got the VR paranoia questionnaire, which is different because it was developed by Freeman et al. And the purpose was to determine situation specific. This is the special thing about this scale. It's about situation specific feelings of persecution or thoughts of reference and positive beliefs. And so it was looking really at situation specific persecutory ideation. That was the point of this scale. And then you've got the sense of presence questionnaire, which is literally presence or the feeling of being present in the VR environment. And then lastly, you've got the semi-structured interview, which was rated by an observer, and that is how it was quantified also on a 6-point scale of persecutory content. That's how it was rated and converted to quantitative data. So these were the methods, these were the materials that were used. The study was designed, remember, to check for correlations between persecutory ideation and the presence of positive beliefs related to how others are receiving you, correlations between persecutory ideation and anxiety, correlation between persecutory ideation and paranoia, and also correlation between persecutory ideation and thoughts of reference. So those are lots of different correlations, and we'll discuss those in our later lesson on the findings of the study and how to evaluate them. But for now, let's look at the first steps in the process. So as with all great studies, the first step in the process was obtaining consent. Consent was administered to all 24 participants who were in the study. But one thing to remember is that the consent provided partial information to prevent what we call priming, which is where you put people in a particular state of mind and then they are likely to respond in that certain way. To prevent priming, they were not told that the study was about persecutory ideation. So they consented to participate in the research study, in the controlled setting, in the VR exposure, but they were not told that this participation was in order to explore persecutory ideation. They were not told this so that they were not more likely somehow to have more persecutory thoughts. So that's called priming. So to prevent priming, partially informed consent was provided, was administered, but all participants consented to participate. And then after their consent was administered, they were given some very basic brief training in how to use the VR equipment that they had. If you recall, they had a headpiece and they had a joystick to maneuver their movements, and you can assume that whatever this looked like 23 years ago, that's what their equipment looked like. So after the training is complete, what happens next? What happens next is that all participants receive this instruction. Please explore the room and try to form some impression of what you think about the people, what you think about the people in the room, and what they think about you. Some impression of what you think about the people and what they think about you, right? So this is a very general sort of instruction, and here what you're seeing is actually clips from the original study. This is what the virtual reality setting looked like, and again, remember, this was in 2003. I know that VR is quite extensive and much more vibrant and rich now, but this is what it looked like back then. So you can see there's one table with two avatars seated here, and as we talked about, across from there there's another table, and this one has three avatars seated across, and again it's a library setting. You can see bookshelves, you know, and this is the virtual reality environment that the participants walked into. They were in this space for 5 minutes, but here's the thing to remember. Before all participants entered the space, half of them were administered the brief symptom inventory, the paranoia scale, the state anxiety questionnaire, and the VR paranoia questionnaire. And the reason for this is to, again, ensure that before participants go into that actual VR space, the baseline, remember pre and post intervention from one of our earlier lessons on self-reports and questionnaires and measurements. So these 12 participants provided a baseline by completing these 5 questionnaires before entering the space and after exiting the space. So basically, before the 5 minutes began and after the 5 minutes ended in the VR space. Now, of these 12 participants, 6 were male and 6 were female. The other half of the participants took all of these questionnaires. They took all 4 of these questionnaires, but they only did them post exposure. So at the end of the 5 minutes, they were asked to complete these questionnaires. And that is how you get a baseline from these people, from this group, and then you can compare it also to the results from this group. It gives you a very good way of sort of trying to control for confounding variables by doing a pre and a post. So this is a procedural point you should keep in mind. And then the sense of presence questionnaire and the semi-structured interview. All participants at the end of the 5-minute period, all 24, were immediately taken in for a semi-structured interview. I think one thing you should remember is that each participant entered the VR space individually. So they did not do this as a group. There was individual VR exposure. That's something, again, that you should keep in mind. So basically, each of these 6 men and each of these 6 women, first, after giving consent and before and after receiving the training, but before entering the VR space, completed the BSI, the paranoia scale, the Spielberger state anxiety questionnaire, the VR paranoia questionnaire, and then they entered the space. On the other hand, you've got these 12 people who are also, by the way, 6 male and 6 female. There was balancing in the way that this was done. They were, after the training, simply given the instruction, these guys, and then they entered the VR space. And right after both of these groups exited that 5-minute virtual reality environment, they were given a semi-structured interview. A semi-structured interview allowed the researchers to get 2 data points. The first data point was, what are your spontaneous impressions? Remember that the instructions were, what are your impressions and what do you think about the people and what do you think about yourself in that space? And then they were also, through the interview, researchers were able to check for any distress caused by the VR exposure. Now, the environment, the library was kept purposefully neutral to prevent confounding factors that may have led to increased thoughts of persecutions. For example, if instead of a library they had used a dungeon, you can imagine that you're more likely to feel afraid and have more thoughts of persecution. So that's why they kept it quite neutral and familiar to the population, because all 24 of these people were a university setting. They were used to a university setting. Libraries are a big part of universities. Anyway, so this interview is followed by the sense of presence questionnaire, which is the last one that's administered. And the sense of presence questionnaire, as we just talked about, is about that being physically present. The brief symptom inventory is a 5-point scale. Paranoia scale is also a 5-point scale. Spielberger state anxiety is a 4-point scale. VR paranoia is also a 4-point scale, whereas sense of presence is a 7-point scale. Do you need to remember this? I say it's good if you do. The reason it's good if you do is because often in your exams you may have to talk about the benefits and the downsides of using these kinds of scales. Now, because here these scales are combined with this semi-structured interview and the interview is further converted into quantitative data, you can sort of say that it's quite a holistic use of self-reports with a little bit of observation to kind of quantify the data from the semi-structured interview. But it gives you insight and access into how self-reports are used in research in psychology, particularly with reference to clinical psychology. That's one big takeaway from your examination of this particular key study, because as you can see, there's a pre and a post administration of these 4 key questionnaires, and they're key questionnaires. Why? Because each of them refers to a particular cognitive or emotional process or state, and the researchers were trying to examine persecutory ideation with reference to cognitive and emotional processes, right? So in the BSI, for example, interpersonal sensitivity is a cognitive and an emotional process. On the other hand, the paranoia scale, quite cognitive, but again has emotional implications. The anxiety questionnaire, very focused on the experience of anxiety, which is emotional but also represents certain cognitive processes. VR paranoia is very much based on the cognitive processes, because if you recall from our earlier lesson, there's a dimension of persecutory ideation within it. There's a dimension of, I'll write them here for you. So there's VR persecution, then there was VR reference, which is thoughts of reference, that you think that everything is related to you in some way, and then there's VR positive belief. And again, this was a correlational study, right? So the researchers followed this procedure because each of these pieces was giving them an important data point that was important to their correlations that they wanted to study. The correlations meaning the relationships they were exploring. The relationship, for example, between the VR persecution or the persecutory ideation and anxiety, or between interpersonal sensitivity in the BSI and VR persecution, or VR persecution and positive beliefs, right? So each of these really gives access to one of those data points that the researchers were looking to examine, and by doing a pre and a post for half the sample, they also have a nice baseline here to compare between the results of these people and these people. And when we talk about the findings, you'll figure out why that difference was so important. but this is a nice way to control for potential confounding variables by establishing a firm baseline. So things to remember: the VR exposure was controlled, and it was done to determine if persecutory ideation would occur in people who do not have any history or presence of psychological disorders. They prevented priming by giving partially informed consent, but they also ensured that nobody in the sample had any history of psychological disorders. Nobody had a psychological disorder at the time of participation. They used quantitative data, which we do consider to be more objective as there is less room for interpretation. But do remember that because the video interviews were videotaped, this can be a little questionable later. But at the same time, because they've administered the questionnaires to half the sample pre and post, and to half the sample only post intervention, they are further able to check if there was any priming because of the questionnaires for persecutory ideation. So there's a lot of really good control measures followed in this method, in the procedure itself, and that is really your main takeaway here. Again, remember, this was an exploratory study in very unknown territory. Can you use VR successfully really to determine or to not determine really, but can you use VR successfully to understand people's experiences of this one phenomena of thoughts of being persecuted? Can you use VR to explore that, right? And so it was important for them to have controls in place, which you can see they have done, to avoid priming, to have baseline endline measurements, and to have their interviews videotaped, to use this much quantitative data in the form of these validated questionnaires, including the one they developed themselves. So these are procedural details that you should keep in mind by remembering these three elements. In the next lesson, we'll talk about the actual findings of the study. Hi guys, welcome to the findings lesson on Freeman's study, which was done in 2003. Sorry about that, that's my error. In this lesson, I'm going to take you through the results of each of the different self-reports that were used, but I'm also going to explain to you how they're all connected and how you can make sense of the findings on a more broader level, in the sense of how the pieces fit together and what the study really demonstrates in terms of its recommendations for future research. So you'll remember that we talked about the VR paranoia questionnaire in our earlier lesson on the methods and the materials, and also we covered it again in the procedures. I want to take you through the questionnaire once before we dig deeper into the rest of the tools, and then how they trace back to this questionnaire, because this questionnaire is actually the most fundamental piece of the research study, of this research study. So first you see these statements. This is actually a copy of the original questionnaire. So you can see statement 1 through 5 are really about the way a person might think other people are perceiving them. So they were hostile toward me, they would have harmed me in some way, had it in for me, trying to make me distressed, had bad intentions towards me. As you can tell, all 5 of these statements refer to persecutory ideation. On the other hand, then you've got these other statements from 6 to 10, and this says they were talking about me behind my back. They were saying negative things about me to each other. They were watching me. They were looking at me critically. They were laughing at me. So here, what is happening is that the person is connecting whatever they are seeing around them to themselves, right? They're thinking that if somebody's laughing, it's about them. If somebody's looking at them, they're looking with a critical eye, that they are watching, they're being watched by someone, that someone is saying negative things about them. So if someone's talking to another person, the assumption here is that they're saying things about me, right here. So this is your thoughts of reference. And then you've got here slightly less negative statements where you've got they were friendly towards me, they were pleasant people, they were trustworthy, they had kind intentions for me, I felt very safe in their company. These statements tend to indicate a different perspective on the other person or people in the space. These statements indicate a degree of positive belief about how one is being perceived by other people, or the way that other people, the intentions that other people have towards one, right? So this is the questionnaire generally speaking. These statements from 1 to 5 will be scored maximum of 7 and minimum 0. These ones related to the thoughts of reference are going to be between 0 and 10, and positive beliefs between 0 and 13. Remember that this scale was a rating scale, and so these numbers are referring to the possibilities of rating and weighted scores, but this is just something we'll come back to. So now let's look at the rest of the instruments before we return to this very important questionnaire. Just remember these three components, and let's now look at the semi-structured interview. Remember that right after the VR exposure, each individual participant participated in a semi-structured interview with the researcher, and these interviews were then rated by a clinician, who was actually Freeman in this case, to determine the presence of persecutory content. So here you can see this table right here is from the original study, the paper that was published by Freeman and his colleagues in 2003, and some examples of comments that people made about the avatars which are positive include people were nicer than real people. That's a pretty positive belief to have about a fictional character in virtual reality. But I smiled and chuckled. This is also showing a positive response to the presence of these avatars. And then you've even got, this was part of a game, flirting but being shy. Again, you know, fun, games, play, very positive. On the other hand, some people did make negative statements. They were ignorant, unfriendly, appeared hostile or rude. It was their space, you're the stranger. And then here, this is interesting. One person was very shy and another had hated me, compared to part of a game, flirting but being shy. So clearly you can see positive and negative statements coming out from the semi-structured interviews. But what you do need to remember is that the results of this, when they were rated on that 6-point scale by Freeman for persecutory content, showed that there was actually a significant correlation between the results of the semi-structured interview and the VR persecution score, which was the statements 1 to 5 that we just looked at in our earlier review of the overall questionnaire. So there was this finding here that there was a correlation that was significant between these negative statements and scores on the VR persecution questionnaire, or the VR persecution component of the virtual reality paranoia questionnaire. Next, let's look at the Spielberger state anxiety measure. Now, this Spielberger state anxiety measure, you should remember, was done with 12 participants before and after, and 12 only did it after the VR exposure, the virtual reality exposure. So these results that you're looking at here for state anxiety reflect the scores of all participants who did this before and after. So these 12 who completed this tool pre and post exposure, this is their results, where you can see that the pretest anxiety mean or average level of pretest anxiety is 34.79. Now, the Spielberger state anxiety tool is scored on a range of minimum score 20 and maximum score 80. Clearly, if the average score is 34.79, it is not a significant degree of anxiety that any participant experienced before they began the assessment. nor is there such a big difference with the state anxiety measure after the completion of the assessment, which kind of tells you that there was not much of an anxiety trigger during as a result of exposure to those avatars. Now we look at the paranoia scale. You remember that this was done to assess levels of paranoia in college students specifically. This scale was developed for that, and in the paranoia scale you see that the again here this was also 12 people did this pre and post, and 12 people only completed it post. Over here again you see the mean is 31.8, and this tool is actually scored between 20 to 100. That's how it's scored. So this is the minimum score of 20 and 100 is the maximum score. So looking at the state anxiety questionnaire and the results of it, you've got to, what you do realize is that there's no real evidence that there was any kind of increase in anxiety. The range of scores for the sample that completed this questionnaire was a maximum of 61 and a minimum of 20. So really, and you think about the standard deviation, there's not a very high change or a very high level of anxiety, paranoia that was experienced. So next, and the reason we're talking about the paranoia scale is also to reflect a small nuance here, where in the original implementation of this scale by Fenix-Teen and Vanderbilt in 1992, the mean was 42.7, but here you see the mean is 31.8. Something you should remember is that these guys, Fenix-Teen and Vanderbilt, used a much larger sample. However, their scale is a robust measure of paranoia. So here you can see the level of paranoia is not very high, it's actually technical term, this is trait paranoia, is not very high amongst the participants. And here again you are looking at results for all 24, by the way, because they did have 12 people pre and 12 people post. 12 people pre and post and 12 people post, which makes a total of 24. But these results are for all 24. Next, you look at the sense of presence questionnaire. The purpose of the sense of presence questionnaire was just to figure out the degree or the extent to which the participants actually felt that they were present during, they were physically present in that virtual reality environment. And so the sense of presence questionnaire is just to determine the extent of immersion. Immersion means feeling that you are submerged in an experience. You're completely in that space, completely present. So to determine this extent of immersion, this questionnaire was administered to all participants after exposure to VR. And the maximum score was 6, and you can see that the mean or the average is 2.3. And what this shows is that there was a moderate sense of presence or moderate feeling of immersion. Now, after this, we're going to start looking at our VR paranoia questionnaire once again. In the VR paranoia questionnaire, now I've nicely kind of labeled these for you: persecutory thoughts, ideas of reference, and positive beliefs. So what they found was that there was a significant positive correlation between persecutory thoughts and ideas of reference. So here you can see a positive correlation. And you remember what this means is that the higher score on persecutory thought statements, the likelihood was again higher that there would be higher scores on ideas of reference statements. However, they also found that there was a negative correlation between persecutory thoughts and positive beliefs, meaning that the higher the likelihood of a person having persecutory thoughts, or rather the higher the score on the VR persecution part of this questionnaire, the lower the score on the positive beliefs part of this questionnaire. So here there is a negative correlation, which was a significant one. So this is the inter-questionnaire correlation data, right? But there are some other correlations as well that I'd like to take you through. Remember, however, this does not mean that persecutory thoughts caused ideas of reference. It simply suggests that there's a strong correlation here, where the higher the score on persecutory thoughts, the higher the score on ideas of reference, meaning that when there are more persecutory thoughts, this is a significant predictor that there will likely be more ideas of reference present. At the same time, the opposite applies when you think about the correlation or the relationship between persecutory thoughts and positive belief, where the higher the level of persecutory thoughts, it is a predictor of lower positive beliefs. So just keep that in mind always so that you avoid getting confused. Correlations are not causal. And this study was a purely correlational study. Now, what you're looking at here is specific references to statements from that VR questionnaire, VR paranoia questionnaire that we looked at earlier on, and the extent of agreement and disagreement that participants indicated. So someone in the room had it in for me. This was the third statement on the questionnaire, meaning that it was part of the 5 statements that were indicating VR persecution. This is number 6. They were talking about me behind my back. This is clearly VR reference. And here you've got the positive belief example, which is obviously VR positive belief. Now, as you can tell, there is a diversity in the level of agreement or disagreement to some extent, but a lot of people disagreed. 15 of a sample of 24 disagreed that someone in the room had it in for me, whereas one person totally agreed with this persecutory statement. And then with ideas of reference, you have again 11 people who disagreed a little and only 2 who totally agreed with this particular statement referring to ideas of reference. Positive belief, they were friendly toward me, very little disagreement, quite a relatively higher level of agreement. So when you look back at these scores now in totality for different sections as well as the total score, you clearly see that if the maximum score here is 7, the average was 2.3, so some degree of presence of persecutory ideation. And here maximum score is 10 and you've got an average score of 4. Again, you're seeing the same, similar to persecution, right? Which is a good thing because that shows you some stability in response. Positive belief scores are 6, where the highest was 13. And again, you can see that, yes, all right, this is moderate response. It's an average of the average, really. So these are some other elements of how you kind of analyze the data from the study itself. Now we're going to start looking at the last significant correlation that I was leading up to. Now, the BSI, or the Brief Symptom Inventory, you remember that it looks at 9 symptom dimensions, and those symptom dimensions include interpersonal sensitivity, they include obsessive compulsions, they include depression, they include anxiety. So they're looking at mood, they're looking at psychosis, but they're always looking at presence over the last 7 days. So that's another important piece to remember of this 53 item inventory. And when the researchers, Freeman and his colleagues, compared the scores in the BSI dimensions to the VR paranoia questionnaire, they found that there was a significant correlation between interpersonal sensitivity and, let me put this here, VR persecution. And they found also a significant correlation between the BSI measure of state anxiety and VR persecution. The reason that the BSI interpersonal sensitivity is highlighted in larger font and bigger in pink is because this one was actually more significant than the state anxiety one, but they were stronger rather, but they were both significant, right? So here you can see that this was stronger, but both significant positive correlations, which means, as you already know because you're great and smart, it basically means that the higher the degree of a score on interpersonal sensitivity, it is a predictor that the higher the score on VR persecution will be. Similarly, the higher the score on BSI state anxiety, the higher prediction or likelihood of a higher score on VR persecution. So now you know all of the data that was collected, you know the results. Let's look at them in summary so you can make sense of how these pieces fit together. So, in summary, positive symptoms of psychosis arise from both emotional and cognitive processes. Remember, positive symptoms of psychosis. Why are we talking about it here? And why are we talking about it in a module on schizophrenia? Is because there are core positive symptoms, meaning indication of psychological dysfunction, that are associated with a schizophrenia diagnosis. And the whole point of this study was to kind of unpack whether VR is a useful and valid space to be able to explore other positive symptoms, but specifically ideas of reference, persecutory ideation, based on the assumption that if previous research shows that VR exposure does result in effective exposure therapy for conditions like PTSD or social anxiety, meaning agoraphobia, or fear of social interactions, then VR should be a good space to further explore ideas of reference and persecutory ideation. Now, another important thing here that you should remember is interpersonal sensitivity and anxiety, both of which are explored, and as we just looked at, there's a very significant correlation here. The reason I'm talking about this is because paranoia or paranoid ideation is a very significant core symptom associated with schizophrenia, to the extent that people who are more vulnerable to people who are more who have higher levels of anxiety, who have high levels of interpersonal sensitivity, who may have a high level of persecutory ideation, may be more likely to develop schizophrenia. And so there's this very clear relationship here. Why are they more likely to develop schizophrenia? Because they are more likely to have a higher level of paranoia and paranoid ideation. So again, this is not a causal situation, it's a correlational situation. So it's about basically a relationship somewhat like this, that when you have a high level of interpersonal sensitivity and anxiety, you are more vulnerable to persecutory ideation. When you are more vulnerable to persecutory ideation, you may then be more vulnerable to develop paranoia or paranoid ideation, or you may have more paranoia or paranoid ideation, and that is strongly associated with the onset of schizophrenia. So that's another finding from this study, and what it does, this finding, is that it points to the potential for future research in these areas. And future research, for example, if this study were to be replicated with people who already have high levels of paranoia, then it may reveal much more interesting insights about the relationship, for instance, between paranoia, anxiety, interpersonal sensitivity, and persecutory ideation. Or it may help us to better interpret the ways in which people experience situations and have ideas of reference. Again, this all really comes down to emotional and cognitive processes. So all of the measures that we've just gone through, from the BSI to the VR paranoia questionnaire to the semi-structured interview, the whole purpose was to unpack or pick apart these emotional and cognitive processes that are related to these positive symptoms of psychosis. Psychosis, again, schizophrenia is a psychotic disorder, so that's another piece. Remember, psychosis represents a split from reality. However, ideas of reference and thoughts of persecution or persecutory ideation are not pathological in and of themselves. When we talk about them as pathology, we do not call them ideas or thoughts, we call them delusions. So please do remember that, and when you are writing your responses for your exams, you must have that distinction very, very clear in your head. Here we are talking about thoughts, but when we talk about delusions, we're talking about fixed beliefs. So that brings us to the end of this lesson on the findings of the study. It's been a little long, but it was important for you to understand how each of the tools has been quantified really to produce this kind of data to establish this basic relationship between interpersonal sensitivity, anxiety, vulnerability to persecutory ideation, paranoia, and then of course coming back to your key topic of focus, which is schizophrenia. Hi, and welcome to the second last lesson about Freeman study done all the way back in 2003. In this lesson, I'm going to give you a quick overview of how you would evaluate this study with reference to the ethics of it, with reference to the methodology used, what were the strengths, what were the weaknesses. So first, we're going to talk about the ethical considerations. Now, important for you to know is that no participant in the study indicated any sort of psychological distress. When we are talking about research done with human participants, one of the biggest ethical concerns is, or actually the reason we have ethical guidelines, is to protect human participants from any potential harm. In this study, there was no evidence of distress, which is uncovered by the fact that none was reported in the semi-structured interviews that were used after exposure to the virtual reality setting. And additionally, remember that the participants also completed the state anxiety questionnaire right after the VR exposure, and in neither of these was there any evidence that anxiety had, for example, increased as a result of the exposure. So you can say there is no evidence, really no evidence, that any psychological distress, i.e. harm, was caused. And this is important, even more important, I guess, because consent was not fully informed. If you recall, we talked about it in an earlier lesson that participants were not told about the fact that this is a study on persecutory ideation, and they were obviously not told this because they were, let me write it, yeah. They weren't told about the study exploring persecutory ideation to avoid any sort of demand characteristics, to avoid any priming, and to keep things valid and reliable. Obviously, we want to always provide completely informed consent, but in this case, what you need to consider is when you weigh the benefit against the harm or potential for harm, in this study, because you can see that there is no evidence that any distress was caused, clearly the benefit really does actually outweigh the harm. And hence you can say that ethically speaking, this study is all right. And this is a really good example of how you apply ethical guidelines. And that's why they're guidelines, that's why they're not black and white. Now, next we're talking about the methodological strengths of this research study. The first thing that really pops up here is that there's a pretty high degree of reliability. The procedure was really standardized, every single participant had this 5-minute window of VR exposure, and the training that was given to all of them was identical. The instruction that was given to all of them was identical. You should be able to identify these things off the bat from your AS level curriculum. Now, a little more that you should know is that they did use a lot of self-reports, but this is a good thing when you consider the reliability, because the measures that they used, which include the BSI, paranoia scale, the state anxiety questionnaire, and the sense of presence, were all self-reports that have been used in the past, and hence you can consider them to already have stood the test of time in terms of revealing consistent findings. So that adds value to this study because it uses these reliable instruments, right? So there is this strength here, and then you talk about the validity. When you're thinking through the validity of this particular study, remember that out of the 24 participants, there were total 24, right? Of the 24, 12 completed all the self-reports before and after, all of them except for the sense of presence. Remember that. So they completed the VR paranoia questionnaire as well as the other three before and after, whereas there was another set of 12 who only did the questionnaires, all of them, after exposure. And why is this so important? Because that provides a baseline to ensure that these 12 people who completed the self-reports before were not in any way influenced by the questionnaires when they were in the virtual reality situation. How do the researchers know this? Because the results of these 12 was similar to the results of these 12 who only did the questionnaire only after the exposure, not both before and after. So this is an important piece. I think in our lesson on RCTs, we also talked about this baseline for comparison. So think about it maybe through that lens as well, although this was not an RCT. So again, this reduces the, it ensures that there was no priming that happened because of the questionnaires being done before, right? And then because they had given this partial informed consent, they did not tell participants the study was on persecutory ideation, and that is important. Why? Because it reduces demand characteristics. Participants did not have in their minds what researchers were looking to examine. And so again, this really does contribute to the validity of the methodology that was used. And then the last piece, that is the methodological strength. Again, this is part of your AS curriculum, but I want to reiterate it here, is that you can think about this as being a lot more objective, because even if they used interviews, do remember that those interviews were rated on a scale of 6, and that allowed the persecutory content from the interviews to also become something that was quantified. And that means all the data was quantitative, and that means that there is a lesser likelihood of researcher bias, conscious or unconscious, in the interpretation of the data. But like all good things, there are also some weaknesses, and that is what I'm talking about now. When you consider the validity of this study, there is low ecological validity. What does that mean? Why? Ecological validity is about to what extent does this study, or the setting of the study, resemble the real world, right? And now this study was done purely using a virtual reality environment, but when you're using a virtual reality environment, to ensure that that environment does actually echo the real world, the researchers used the sense of presence scale. Remember that scale where it measures the extent to which you feel physically present in a virtual reality space, and you kind of feel like, okay, I'm not just looking at visuals, I'm actually in this environment. So on that scale, when you look at the results that this study produced for this particular instrument, it was a very moderate sense of immersion, which means that there is slightly lower ecological validity, because participants may not feel like they were fully in that actual virtual reality space, and hence you can assume maybe they did not behave the exact same way as they would if they were in the real world, in an actual, for example, library with an actual 5 people sitting there and exhibiting unambiguous behaviors. So that's a little weakness here, which is revealed by the sense of presence scale. And the other piece here is that they use the VR paranoia questionnaire, and you will notice that I didn't mention this questionnaire in the earlier one where I was talking about reliability. Why? Because this paranoia questionnaire was developed by Freeman and his colleagues for this particular study, because when they did this study, they were unable to find any other already tested measure for situation specific or state persecutory ideation. Hence they developed their own. And if you read the original study, they do talk about the sort of downside of having done this. Now all the items that they have face validity, and you'll remember the items are like, you know, they were all they were laughing at me, for example, is one of the statements on that scale. So clearly it's very simple language, it has very high face validity. However, it wasn't pre-tested, so there's no data norm to measure it against. Hence you can think about it as a slight weakness, because it needs to be further tested for validation. Remember, validity is, does a particular measure continue to accurately produce the same responses over and over and over again, which indicates that it is actually measuring what it is supposed to measure over time, right? And so that's temporal validity, if you recall. And so remember that this piece is also important when you're thinking about validity. And the last here is that generalizability is an issue. Why is it an issue? Because the volunteer sample was all university students, they were all young. There were 21 students and 3 administrators, right? So you have 21 students and 3 administrators, but they were all volunteers, which means that they responded to an advertisement and chose to be there. They were obviously interested in psychology, or maybe remember that they did receive payment, right? So maybe they just did it for the money. I'm not sure if that's true, that's a big assumption, but what we can assume is that there must be a certain degree of intelligence that they already had, and possibly an interest in psychology. They were all within that environment of the University College of London, so you can, I think, realistically assume that level of intelligence. This means that there is what you can call the possibility of sampling bias, and when you have sampling bias, this essentially means that your results may not be generalizable to a larger population. And one more important point, which is not written here, but I do want you to remember, is, and I'm going to write it right here now for you, is that nobody in the sample had any history of psychological disorder, which means that these findings cannot be generalized in any way to any person who has any history of mental health illness. So that brings us to the end of our little lesson on evaluating the study, and in the very last one that's up next, I'm going to take you through the applications of the study as well as the issues and debates that are relevant to it. Hello, in this lesson, which is part 1 of a 2-part lesson, and we're going to cover the diagnostic criteria for schizophrenia. We are focusing on the criteria as listed in the ICD, which is what you do use in your A-level syllabus. And this lesson is going to focus on the positive symptoms of schizophrenia. So let's begin. Now, you will remember from our previous lesson that positive symptoms are symptoms that indicate the presence of psychological abnormality, meaning that there is identifiable psychological dysfunction. We are going to talk about the core positive symptoms. These are called core positive symptoms because they are the most significant of the psychological dysfunctions present that will indicate schizophrenia. We're going to look at each of these in detail, but before we do that, just very broadly defined, when we talk about hallucinations, an example is when you think about people hearing voices. You talk about experiencing passivity. An example could be when you come across somebody who has schizophrenia, who thinks that they are controlled by aliens, and delusions, which are fixed false beliefs, do not represent reality in any way. And also recall that these positive symptoms may be present in the prodromal stage, which is where all the symptoms are milder, which is why the prodromal stage diagnosis is quite difficult to reach. And you should remember that at the active stage, where there is full psychosis, the symptoms are obviously quite severe. Remember that psychosis is basically break from reality. And one important thing about people who have schizophrenia that you should remember is they're frequently quite helpless because they do not have the ability, because of the disorder, they have lost the ability to even be aware of the fact that something is wrong with them, that something is happening to them that is not okay, that they are mentally unwell. So it's a very sad thing, but it's again representative of that split mind, of that disconnect from reality that is so characteristic of schizophrenia as a chronic psychotic disorder. So these are the core positive symptoms that are also included in the ICD. Let's look at each of them in more detail next. So the first thing we're going to talk about are hallucinations. I'm sure you're familiar with what a hallucination is, but what we're talking about right now is a hallucination as pathology, meaning a hallucination as indication of a disorder or illness. In schizophrenia, hallucinations are defined as involuntary perceptual experiences. Involuntary meaning that the person has no control over these perceptual experiences. Perceptual experiences here refers to, and think about it this way, perception is coming from your senses, right? And your senses are sound, sight, touch, smell. And hallucinations, these perceptual experiences that you have no control over, are hallucinations. Why? Because there's no external stimuli to cause these perceptual experiences, meaning that you may hear things without there being any actual sound. You may see things without them actually being there. You may feel like you are touching things that don't actually exist. You may smell smells that don't actually exist. So there is no external stimuli present for these involuntary perceptual experiences that we call hallucinations. It is like seeing people who aren't actually there, hearing voices that aren't actually real, touching things that aren't actually there, or even smelling things that don't exist in your environment. And those are the markers of hallucinations as experienced by somebody who has schizophrenia. It is a positive symptom. Why? Because it is indicative that something is not functioning. In this case, hallucinations refer to perceptual dysfunction or a dysfunction in our sense perception processes. Next, we will look at this experience of passivity or control or influence. So they essentially refer to the same thing. Passivity is basically having no power, and experience of control meaning external control, and actually influence also meaning that you are being influenced by an external force. Now, these are subjective experiences. They are called experience of passivity, control, or influence within the ICD, but they really do refer to this subjective experience, meaning this feeling of being controlled by something else. An external force has control. This experience or this feeling of having no control, this experience of passivity or feeling of having no control is linked to the fixed beliefs that are delusions that we're going to talk about next. But again, why is this a positive symptom? Because when you have normal, typical psychological function, you do not experience external control over your thought, for example. And so this experience is marked by, for instance, something called thought withdrawal, where you feel where a person who has schizophrenia feels like an external force is literally removing their thoughts from their minds. Then you've got thought insertion, where the person feels that an external force is adding thoughts to their mind. And then you've got the last one, broadcasting, where the person feels that thoughts that they have in their minds are visible to everyone or to others. So these three examples of how that feeling of control is exhibited. So for instance, by thinking that your thoughts are being removed from your mind by aliens or by military forces. And these are common experiences of people with schizophrenia, where they feel like the aliens controlling them. Again, remember that in no way is there this has absolutely nothing to do with reality. This is why schizophrenia represents a break from reality. So these are the three sort of examples in the ways of which this experience is felt. There are others as well, but we won't get into them right now. And the last positive symptom, that is a core symptom, you have to know of, are delusions. Again, delusions are a pathology and similar to our experience of our feeling of having no control. Delusions are fixed beliefs, but these fixed beliefs completely and absolutely contradict reality. They do not represent reality in any way, and they really can range from fixed false beliefs about everyday things like a person who has schizophrenia may believe that the electricity in their homes is coming from lightning of the gods, for instance. But they may also range to the surreal. So they may believe, for instance, surreal meaning they may believe that aliens have abducted them and brought them back to Earth with superpowers, which now brings me to the three main types of delusions that you need to know. The first one is called delusions of grandeur. Grandeur means grandness, quite literally, and it is the delusion or this fixed belief of, for instance, having superpowers. So the person who has schizophrenia will believe that they have special abilities, for instance. And then you've got the delusion of persecution, and you will see this in the key study, which is all about persecutory beliefs that people with schizophrenia have. Delusions of persecution is that people are out to get them. So people are their enemies. And if this could be people, this could be aliens, this could be anything really, but the basic thing is that that person with schizophrenia believes that they are the object of persecution. Persecution is essentially when you're subjected to cruelty and violence and harm. When somebody harms you, you're being persecuted. And so people with schizophrenia may have this fixed belief that there are people, aliens, whatever, that want to harm them, but that belief again has nothing to do with reality. And then the third type of delusion that's quite common also is called the delusion of reference. In the delusion of reference, the person with schizophrenia thinks that everything that is happening because of some sort of personal significance. It is about them. Everything is about them. They may see signs around them that indicate that, for instance, the opening of a door is some sort of special sign meant for them. So as you can see, this relationship here is quite clear now between this experience of passivity or experience of being controlled by external influence, and then believing, that experience, that feeling can lead to this fixed belief, this delusion, for instance, that somebody is sending them a message that is special. So that's an example of how that feeling of passivity can lead to the delusion of reference or referential delusion. So these are the three core positive symptoms, but there are other positive symptoms as well, and I want to take you through those next. Now, these positive symptoms are related to cognition, meaning thought processes. They can also be related to behavior. So the first one up here is disorganized thinking or derailment, and this basically means when a person with schizophrenia is absolutely unable to follow a train of thought. They can't kind of talk in a coherent, they can't think also in a coherent way. This is also called derailment. So quite literally, if you have a train and it goes off the tracks constantly and it keeps on derailing, it keeps falling off the track, going in a different direction. So that's how their cognition or thinking becomes dysfunctional. Again, positive meaning presence of dysfunction. Disorganized speech is related to disorganized thinking, right? And here the language, the communication really is very, very disorganized. It often makes almost no sense, usually doesn't make any sense at all. It's incoherent speech, and sometimes you can call it word salad, because literally it will be a string of random words that have absolutely no sense when they are put in a sentence together, except the person with schizophrenia will say them as if they are a complete proper sentence. And the third piece here is disorganized behavior, where the actions have no coherence. So these are some examples of other positive symptoms of cognition that are cognitive or behavioral in nature. Derailment, word salad, disorganized behavior. Again, representing the same piece that all positive symptoms have in common, which is the presence of cognitive or behavioral dysfunction. So these are the key sort of things to remember. Now, putting it all together in the ICD, you know that core positive symptoms will form the dimensions. There are 3 of the 6 dimensions on which the person is rated by the clinical psychologist. And positive meaning that there is a psychological dysfunction present. These are usually much, much milder in the prodromal stage, which makes it harder to diagnose. And like we talked about in our earlier lesson as well, clinicians have to be mindful that there may be cultural differences. So hallucination may not necessarily be pathological if it occurs in a different way, if it occurs, let's say, in the case of a shaman, or in the case of a peer who may say they see what will happen tomorrow. So that does not mean that they are schizophrenic. So again, cultural differences must be kept in mind. And importantly, as we had talked about in our earlier lesson, other possible causes must be eliminated before the clinician can come to the diagnosis of schizophrenia. So for instance, if there is drug abuse, or if the person is on some sort of other medication, then the delusion or the hallucination or even that feeling of no control can be resulting from this as opposed to from schizophrenia. So these are the positive symptoms of schizophrenia. And next we're going to look at the negative symptoms, which indicate the absence of normal psychological functioning. Positive symptoms indicate the presence of abnormal psychological functioning. So let's get into that next. What are negative symptoms? Hello, and welcome to part 2 of our lessons on the diagnostic criteria used to assess the presence of schizophrenia. In this lesson, we're going to look at the negative symptoms that are associated with schizophrenia. In the previous lesson, you learned about the positive symptoms, which indicated the presence of psychological dysfunction. In this lesson, you're talking about negative symptoms, which are symptoms that indicate the absence of psychological normality or functioning. So negative symptoms are symptoms that indicate the absence of psychological normality. Let's look at the ones that are associated with schizophrenia. So negative symptoms within the diagnosis of schizophrenia will cover different areas. So negative symptoms in terms of emotional experience, in terms of motivation, in terms of communication, in terms of social interaction, and in terms of pleasure. And we're going to look at each of the actual symptoms. And before we do that, I'm going to quickly just also take you through them here. So when we're talking about negative symptoms or the absence of typical psychological functioning with emotion, we are looking at something called flat affect, which we also talked about in our first lesson on schizophrenia. When we're talking about motivation, we are talking about something called avolition. When we are talking about communication, we are talking about something called alogia. When we are referring to the absence of normal functioning in social interaction, we are talking about asociality. And lastly, when we're talking about the absence of normal functioning with reference to pleasure, we are talking about something called anhedonia. Do remember that these are not referred to as core. These are not core symptoms. And there are different reasons for that, but essentially the reason they are not core symptoms is because each of these will overlap in some way with other disorders as well. However, the presence of these in addition to the core symptoms, as well as some of the other symptoms that we talked about in our first lesson, taken together, will indicate either the active or the prodromal stage, depending on the level of severity of the symptoms. So now let's look at each of these in turn. Flat affect. Whenever you see this word, whenever you see the word affect, do remember in psychology we are using this to refer to emotional expression. Affect will always be related to emotion. Wherever you see it in psychology, it is very different from that word effect, which we are talking about when we're looking at cause and effect. So this affect is not the same, especially for your exams. Please do not spell this with an E, because that will be absolutely incorrect, right? So flat affect means that the person has very restricted or non-existent emotional expression. They do not experience emotion. They do not have the same emotional flow or those highs and lows that we all have as part of our typical functioning. Because again, remember, negative means the absence of normality, and so flat affect indicates that the person does not have the capacity for normal emotional highs and lows the way that somebody without schizophrenia would have. Next, you're looking at avolition. So volition, this word volition, actually means the impulse to act, and it's driven by goals that you want to fulfill. Avolition means no impulse to act to achieve a goal. And so again, the absence of volition is avolition, and it means the person has no interest or is unable to engage in goal directed behavior. And this can really be anything from, for example, getting groceries, such an everyday task, but it can even include something like tying shoelaces. They simply cannot act in a way that will enable them to fulfill the goal of tying shoelaces or putting their shirt on, or going to the store to get groceries. So it's really just there's disinterest or a complete inability to act in ways that would fulfill specific goals when you're talking about avolition, so the absence of goal directed behavior. And then you've got alogia, the lack of spoken language. People who have schizophrenia may exhibit little to no spoken language. They may not talk to anyone around them. They may be completely silent. So alogia. Logia here, remember it in this way. Logia, log is about language, and a lot of these words have Greek origins, just like schizo means mind, that comes from the Greek, and schizo meaning split comes from the Greek, and phrenia meaning mind also comes from the Greek. So split mind, split from reality. Now from alogia you proceed to asociality. Again, this A here means it's not there. So social withdrawal. The person who has schizophrenia will tend to become completely isolated, will not interact with other people, and may become very, very completely absorbed in this sort of own world that they have, and be completely asocial. So they have lost that ability that is so essential of a normally functioning human being, to be connected to others. So that's asociality. And then you've got anhedonia. Anhedonia is the inability to experience pleasure, no capacity of feeling, no joy, or no happiness, or laughter. And you know that these are very human things. The experience of pleasure is a very human thing. And as I have shared with you the earlier roots as well, hedonia refers to joy or refers to pleasure. So anhedonia means no pleasure, no joy. Now, this is an example of one of the symptoms that overlaps with a different disorder, which actually the other ones do as well. But anhedonia particularly, you will study it later, so I'll tell you now. Anhedonia is also one of the symptoms of depression, this inability to experience any pleasure or joy. So there is an overlap here. And that is why anhedonia alone, or any of these others, asociality alone or alogia alone, solo, they will not be able to, taken in isolation, just one of these symptoms cannot be used for a diagnosis of schizophrenia. The core symptoms we've talked about earlier will be present. Now, the negative symptoms taken together still do form one of the 6 dimensions in the ICD. So they are very much still considered as part of the diagnostic criteria. Just because they're not core does not mean that they are not assessed in the diagnostic process. Please remember that. They are part of these 6 dimensions. They are rated on that scale of 1 to 4. They indicate the absence or this gap in normal psychological functioning, of typical psychological functioning, clinicians must account for cultural differences when they are making this diagnosis, because, for instance, in some cultures it is possible, for instance, that women are not encouraged to talk, and they are not encouraged to to engage in social interaction, in which case the asociality or alogia that is seen may not be pathological. So again, this cultural difference must be accounted for. And lastly, similar to what we had talked about with our positive symptoms, the clinician must exclude other possible causes, substance abuse or trauma, trauma or abuse or drugs. All of these must be excluded for them to really say, okay, these negative symptoms, this absence of normal psychological functioning, taken together with a core symptom that also cannot be explained by any other reason, they do indicate the presence of schizophrenia. So this is how you would treat negative and positive symptoms. And next, we're going to look at an example study which will tell you how these symptoms really express themselves in a very rare case of very early onset schizophrenia. Remember, in our first lesson, I mentioned that cases of childhood schizophrenia are very, very rare. So we're going to look at that in our next lesson. Hi everyone, in this lesson you're going to start on the first of the 5 psychological disorders that are part of the clinical psychology syllabus. So in this lesson we're going to start looking at schizophrenia. This is a very, very basic overview, so you